And I think when we look at some of the challenges that we have just in general, we do a great job of actually showcasing evidence-based practice in the literature and in the guidelines, but we really don't do such a good job of taking it directly to the patient's bedside. So here are my disclosures, as well as the objectives for today's program. We'll make a recording of this available as well. And I think that we have to start and end with the patient, and I think that's so critically important. The patient should be the center of the universe as it relates to our care that we're providing with vascular access, infection prevention. It doesn't really matter. And we have to be more involving of them in infection prevention, and I think that's so critically important. The second thing that we have to incorporate is really how does healthcare-associated infections get correlated directly back to the AAA. And so these infections do have that direct correlation to the Institute for the Healthcare Improvement. And this is really the fundamental piece, if you will, of healthcare reform. The first and overarching goal is to improve the health of a population, but that has to be coupled by improving the experience of care and reducing the per capita cost. And if you were to transpose this back into vascular access, we know that if you get the right clinician to put the right line in for the right patient for the right duration, that their length of stay is going to be decreased, that their infection rate will be decreased, and that's going to help us with cost as well as improving patient satisfaction. We also know that there's going to be rapid change ahead in healthcare, not just as it relates to bloodstream infections and things like we're talking about today, but just in general. Part of that is going to be a movement towards outpatient settings, which we're going to talk about here in just a second. But it also opens up Pandora's box for situations that we may not have studied or we may not be familiar with. There may not be a guideline out there for these issues. One of the topics that I actually just spoke on earlier today was Ebola. And believe it or not, the CDC has recommended that all of the infectious waste be treated as what they call a Category A pathogen, which means that no one can transport it outside of the hospital unless it's already been treated and sterilized, essentially. Well, this is very problematic when you look at certain circumstances lately where we've had 3 Ebola patients and several thousand pounds of trash that are generated because all the linens have to be actually discarded as infectious waste, and many hospitals cannot treat on site. So why do I mention this? Because we have emergent issues that happen in infection control and prevention in vascular access that we have to think through what does the evidence say, but not only what does the evidence say, but how is it then implemented actually at the bedside. And that's an example of what we have a recommendation, but we really don't have cooperation from other federal agencies to transport this material off to somewhere else. So what is evidence-based practice? Is it our friend or is it our foe? And I think it's really a mixture of both, and it's what you make of it. First of all, you actually need to make it your friend and use it when appropriate, but not over-rely on it. And an example of this could be you're sitting at a meeting with a colleague, and they say, well, there's no evidence-based practice for that. But you know that what you're asking them to do is common sense. It could be something as simple as hand hygiene. It could be involving the patient in their own care. That may make the staff member a little bit more uncomfortable. I remember when PALS updated their guidelines, and they really talked about the value of having the parent or loved one or caregiver in the room if a child was going south during a code and explaining that to them so that they weren't so dramatically moved if the patient didn't survive because they knew and they witnessed all the interventions that were taking place. And that made a lot of caregivers very upset and potentially intimidated by having a parent in the room. And I could certainly understand that, but that's an example where the evidence lends us to making tough decisions and making it more of our friends. The next thing I'd like to talk about a little bit is the importance of a checklist. And I think that we can learn so much from other industries, whether it be the airline industry, manufacturing, other types of safety environments. You go into any major manufacturing facility in the U.S. and you're going to see it's been so many days since their last accident, and that's publicly reported to OSHA. But not as it's just publicly reported, it also is something that moves people to say, we need to take this very seriously. It's always in our face. But it also shows your patients, or in the case of the manufacturing facility, the customers, that they take safety very seriously. And you have to follow that designated checklist in order to do something systematically, which is all about evidence replication. Something that I think is very telling is that the Consumers Union is really questioning, well, if we know that there's good evidence-based practice out there, why are we not doing more to prevent healthcare-associated infections? I think that's a really logical and fair question. If we know what to do for most of these scenarios, why is it that about 60% of the time we just simply don't do it? Is that malicious behavior? Well, I think not. Is it lack of resources? Absolutely. Is it lack of education and training? Absolutely. Is it lack of accountability and C-suite support? Most definitely. And it's not just one factor, but it's all of these things that go into implementation of evidence at the bedside. And I think the consumers do need to be asking these hard questions, and we as healthcare professionals need to answer them. And not just answer them amongst our little circles, but more importantly, get the patient and the families engaged so that we can understand their perspective. You know, they're not just checking into a hotel, they're actually checking into a hospital or a healthcare facility with an expectation that they will actually get good quality care and they will be cared for in a safe environment. So just as we just mentioned safety, I think it's important to talk about the Swiss cheese model. So if you think about how do we actually have an accident happen, well, it's when all the risks line up in a perfect direction, moving in the same direction, and it creates an adverse event or eclampsia or fall or some other type of unsafe work environment. And we want to move away as much as possible to systems that are designed to fail. We need to figure out and work with our colleagues in engineering and safety and risk management and infection prevention to understand how these systems that we might have are failing. Now, as we move on, this is an example of a system that does work. And this is from the World Health Organization Checklist for Safer Surgical Care. And I show this because I think it breaks it down into the right level of simplicity. You have the care states, if you will, so before induction of anesthesia, before the skin incision, and after the patient leaves the operating, or excuse me, before the patient leaves the operating room. This really helps us understand who's doing what, who's responsible for it, but more importantly, that everyone is doing it consistently. So if we think about wrong site surgery, well, that should never happen in the United States of America. There's no way that that should happen, yet it continually does. The reason that it continues to happen is, of course, because we don't follow the systems every time. We design the systems to fail, and we design the systems with the objective of putting the system in place versus having the objective of decreasing the actual error that we're trying to prevent in the first place. Now, if you fly, you probably have experienced this with TSA. You know, you only get one carry-on and then one personal item. Well, who came up with the evidence for that rule? And what evidence is there that says that that is going to make us safer? Well, the answer is we don't know, because there really is no evidence for that. And I think that's something that we should certainly consider, but also things like the liquids amount that when you go through the airport. Well, how do we know that 3 or 4 or 5 ounces is going to make any difference if someone really wants to cause harm to others? Well, there's really no evidence for that. And so we have to continually up our game and figure out, is what we're doing working? If it is, great, what are we learning from it? But if it's not, how do we continue to adapt the system in order to take waste out, improve efficiency, and improve clinical outcomes? Now, given the whole state of Ebola, I thought it would be very wise to talk about the difference between an outbreak and endemic and how that translates to evidence, which we'll finish up with in today's program. But endemic problems are basically where the system, the culture is the problem. It's not an isolated event. It's not an Ebola. It's not a one-time flu outbreak of a novel flu. It is things like CLABSI prevention, the use of personal protective equipment, the use of hand hygiene when appropriate. These are endemic problems that actually cause the majority of healthcare-associated infections. And I kind of broke it down into device-associated infections, procedure-associated infections, and adherence problems. So if we look at hand hygiene, that's going to fall under adherence, personal protective equipment, adherence. But they have impacts to the device-associated infections and procedure-associated infections. Now, caries, CLABSIs, VAPs, all of the like there, and then surgical site infections. But there is a way for us to start to move that tide, and part of it is multidisciplinary collaboration, but then creating outcomes that are specific to our patient populations, in this case pediatrics, that will help drive national change and transformation. The other piece we have to consider is, how does that relate to healthcare? Well, if healthcare is moving more to outpatient settings, we know that our patient acuity is higher. We know that especially in pediatrics, we're able to provide technologies that will really allow preemies to be born more prematurely. We also know that there's patients that have very significant immunocompromising issues. This is something that we have to take into account as to how we're going to care for these more ill patients with limited resources. You know, you don't really get a lot more FTEs these days. It's really about how do you do more with what you have or less. The other thing, too, is the special environments, is intensive care settings, infusion services, and primarily outpatient settings and ambulatory settings I'm very concerned with. These outpatient settings don't always have the same level of sophistication. The staff members may not be nurses, so you may have more medical assistants, and they have a high risk for outbreak, especially if they do procedures. An example of this that's very common right now in the U.S. is the use of scopes for things like colonoscopy and endoscopy, and they're not being properly reprocessed. And so if you think about that, you know where they go. They can become heavily contaminated and soiled, and so there's a cleaning process that must take place prior to the high-level disinfection. And if you don't do that, you're going to have all that gross organic matter and the soil still in there, and it's not going to be removed through just the actual terminal disinfection process. Now, healthcare certainly does not exist in the four walls of a hospital, but most of our guidelines and our evidence does exist only in the hospital setting. So it's very rare that you see specific studies or guidelines or recommendations for outpatient settings. I do think that's starting to change, especially with infection prevention. CDC has especially come out very strongly and said we realize that there's a need for recommendations specific to outpatient settings, and I think they've acted very aggressively, which is a positive thing here, and published the first recommendations for infection prevention for outpatient facilities. And I think that's moving in the right direction. What we do need, though, more than anything is recommendations about specific patient populations, both the old and the young. And so that's one of the things that I think is very helpful to have the pediatric SIG, is to look at those evidence-based questions and create research projects so that you can answer these hypotheses. Looking forward, though, I think it's important to look forward is the challenges of tomorrow. We've talked about that patients are going to be of higher acuity. We know that there's going to be more resistant organisms. The FTEs and the resources that we have may stay stagnant or not increase, or certainly could decrease. Reimbursement is changing, and I think that's huge. That's driving so much of change in healthcare right now that we have to be much more proactive in managing some of these resources, especially staffing and beds and things of the like. Excuse me. And then you have transparency and public reporting. This is huge. I think the public certainly has the right to know what they're getting into. That being said, we have to stratify that information and ensure that what we're providing them that's viewable online makes sense. If it doesn't make sense for the patient, it really shouldn't be published. And I think they have to be taught how to interpret that, or better yet, let us publish some meaningful data that help the patient and their family make an educated decision about their health care. You know, going under the knife in surgery is not something that people want to do. It's not something that people just aggressively say, I'd like to get up and have surgery. It's usually an elective procedure or obviously an emergent issue, and they're very scared. They're terrified. But the evidence shows us that if we take that extra couple minutes and actually explain to them the procedure, what we're going to do to ensure they have a safe outcome, makes all the difference to the patient. But again, going outside of our comfort zone is very helpful. Transition a little bit into some of the recent evidence that's come out about infection prevention, and some of the scary stuff is antimicrobial resistance. If there's one thing that scares CDC right now, it's antimicrobial resistance. It's not Ebola, it's not flu, it's antimicrobial resistance. Because we know that in the next 10 years, and this report was released about a year and a half ago, so you're talking about basically 8 years, that we're going to run out of antibiotics as we know them today that will work against these very, very vicious organisms. The estimate is about 2 million illnesses, which is really directly correlated to 23,000 deaths. This is only for bacterial and fungal pathogens. It's the first time this data has ever been studied, and I think it speaks volumes to the fact that we have a big problem. Part of the improper prescribing does exist in pediatrician offices, and CDC really conducted a study looking at, well, what's the expectation of the patient that they have? When they come in and they pay their copay, do they expect to receive a prescription, or are they okay if we tell them, hey, a prescription is not clinically indicated, therefore we're not going to give you one, but if you continue to feel poorly, you know, certainly let us know and we'll reevaluate you at that point. Well, that sounds fine and dandy, but many pediatricians, as well as other healthcare providers in general, so it's not just a pediatric problem, do certainly prescribe antibiotics because the expectation of the parent is that they will receive something for their child to make them improve as far as their care. In reality, we know that that's not always the case. We certainly should not be giving antibiotics to viral infections. So CDC took this a step further, and they said, well, let's study this information. Let's see what we can find out. And so they developed a prescription pad that you can actually go online and order for free, and they gave that to the parents and had some very over-the-counter remedies like use a saline spray. Actually take some Mucinex D. Make sure that you're irrigating out your nose as much as possible, sanitizing your hands. And they gave that to the parents, and they said, here are your recommendations, or your prescription, if you will. Go ahead and take that to your local pharmacy and have it filled. Well, the parents didn't care that it was not a prescription. The pharmacist still could, quote unquote, fill it. But they saw that the outcomes of poor prescribing practices went down and satisfaction did not suffer. And so that's what we're looking for, is how do we improve operational efficiency clinically, but also improve the actual outcome, the endpoint, if you will, for the patient. And this is just one example. This slide shows you the 3 most common resistant pathogens that are listed as urgent, meaning that we must do something immediately in order to tackle that. The number 1 pathogen is Clostridium difficile, so you're looking at about 250,000 infections per year, resulting in about 14,000 deaths. And I think when you look at the total number of the spend, if you will, you're talking about a significant amount of healthcare delivery dollars are spent on just these 3 infections. And the one that always surprises me is the drug-resistant gonorrhea. This is not something that I would have ever thought would have shown up in this particular list, but here it is. Taking that a little bit further, what's the evidence say about how antibiotic resistance spreads? Well, we know that it's not just a healthcare problem. It also goes back to our communities, the actual products that we consume, such as our food supply, what we drink, and then also our interactions with the environment in general. And so we have to take that into consideration as to how do we change these practices when they're outside of what our traditional scope is. So CDC put together some evidence-based recommendations. Well, how did they come up with these? They looked and they talked to others and they said, what are the things that we can do to move the needle forward? They also published literature and looked at published literature, and they broke it down into 4 basic steps. They said, first, we've got to prevent the infection by preventing the spread of the disease, putting people in isolation immediately. We look at the enterovirus outbreaks that we're having here in the U.S. We need to protect our staff members as well as our other patients from these viruses. Tracking is important. We need to learn from the data that we collect, and that's so important. We need to learn from the data we collect. We cannot just collect data to collect data. And we do that so much in healthcare where you have to enter this and capture that. Well, what is being done with that behind the scenes? And then how is that, more importantly, communicated back to the frontline staff members at the bedside? If we don't know that we have a problem, we can't improve upon it. The third is improving antibiotic prescribing and use. This is where what we call the stewardship program comes in. So we're trying to measure and actually sustain the use of our antibiotics in a way that is going to clinically control them. That if a patient does need a very powerful antibiotic, there's a system in place to evaluate the need and then, if necessary, prescribe it. And then the last is not certainly the least, but it's developing new drugs. We cannot continue to live in a world where we have very limited drug development. And the reason that people don't develop new antibiotics is because there's no money in it. And so the FDA has really stepped in, which I'm very proud to say that they're doing that. And they're saying, we're going to provide you some monies to the pharmaceutical companies to develop new antibiotics, new vaccines that will help us move past all of these different deadly infections that we have out there. So transmission occurs by 3 common sources: the contaminated skin of the patient, the contaminated hands of the healthcare provider or the patient, and the environmental surfaces. And so when we go through some of these next slides, it should hopefully tie that together. We're kind of trying to break apart that sweet spot. Because you know that the hands contaminate the environment, for example. We know that the hands contaminate the skin. Well, we've got to move away from the prevention of transmission and move towards the prevention of the pathogen. So what I mean by that is that influenza, as an example, does actually spread via the droplet route. It's not an airborne virus, which a lot of people think about. It's not. But we have to move away from just reacting to it and actually do more prophylaxis and say, what can we do to actually prevent the pathogen? Well, we can administer the flu vaccine. We can teach people how to cover their cough and sneeze into their elbow. We can teach them how to use an alcohol-based hand sanitizer. These are ways that we will hopefully reduce the incidence of flu, but not just focus on the transmission. Now, Ebola is another thing that comes up, and I see we already have one question about Ebola. Well, Ebola is a bloodborne, virus. It is something that is transmitted via that particular route, and we have to protect ourselves from that. So knowing a little bit more about the specific pathogen is helpful, but we don't have to treat it any differently, if you will, from other bloodborne pathogens. And that's something that I really want to stress here because that's a question that's come up very frequently. The sources of evidence, though, get really boggy and confusing. So how do I know where to go for what? And how do I know what's going to be used in a court of law, for example? How do I know that the physician is going to agree with me? Well, the answer is you don't necessarily know the answer to all those questions, but we do know that from a litigation perspective, they're typically going to go to the most nationally evidence guidelines, specifically the government. So they may go to the CDC guidelines for emergency bloodstream infections. They may ask that, well, what did you do, and how does this compliant with your particular practice? They may say, well, let's look at the Infection Prevention Society. Let's see what they have to say. Well, my argument to that is that infection preventionists don't necessarily do vascular access. They don't actually take care of patients at the bedside. So you're better off going to something that's very specifically targeted for your question and then using that as your source of evidence. And there's nothing wrong with pulling from multiple different guidelines, documents, or other evidence-based resources to say, hey, this is what I'm going to use from this one, and because it makes the most sense for our patients, and we're going to use this from this one. The key comes into, or basically where the key comes into this, is that you want to follow all your Category 1 recommendations to your highest rank, regardless of what you're looking at. The other things you may pick and choose based on the patients that you serve. Now, to implement evidence-based practice, you have to remove organizational barriers. And I think part of this is creating the right culture. And we're going to talk about a few just quick tips that you can use. But you have to understand the goals and the vision, and that has to come from the top. It can't just come from the bedside, but the leadership must fully integrate the vision and the goals of the team as well as the organization into everything that they do. It should be palpable and visible all the time. You also can't allow for complacency. As soon as you get complacent is when people die, because you get very, very hung up on the fact that we're good, we don't need to deal with that. The other thing that you can do is create a change management team. There's actually designations out there that you can pursue called change management specialists, and it's very interesting to watch people that work in that field. All they do is go around and deal with problems. They're helping people achieve greatness by removing obstacles both personally and professionally and at the institution level. Now, the other thing, too, is that you can't say, well, I can't do that. That's not a good answer. You have to say, I can do it, but I need to do this first, or I need this obstacle removed in order for me to win. I think that's so, so important. Short-term wins are huge. Short-term wins are things like, I reduced collapse rates by 30% this month, or we went a whole month without a collapse in. It's the first time that's ever happened. So we should definitely celebrate that with a good intention, but also remember that we can never take our foot off the pedal. And we've always got to press forward, because if you declare victory too soon is when you can run into problems. Now, the Institute for Healthcare Improvement has the triple aim, but then if you look at the Team Steps model, they have this, what they call the shift towards a culture of safety. And it's a great flow chart that talks about what we do well, what we could do better, and really what will get us towards our end goal, which is sustainability. If we talk about this in infection prevention terms, well, it's good to have a collapse team. It's good to have people sitting at the table, but if we don't sustain that past whatever our initial target is, it's really worthless. Now, if you think about the 3 stages, we do the first phase, which is assessment and planning and training and implementation, fairly well. Implementation we are lacking in, but we do an okay job. Where we really fall down is sustaining the outcome, making sure that what we put in place becomes hardwired. And we know that on average it takes about 17 years for an evidence-based practice to go from the guideline of the literature through administration, through the nursing leadership, to the bedside nurse, and actually be hardwired for every single patient. If ever, that's just an average. Now, how does that really line up, if you will, with the different performance indicators? Well, we have to have a good balance between performance, knowledge, and attitudes. And part of that is the leadership culture. It has to come from the top. We need to ensure that what we're doing is going to actually work. If it doesn't work, we have to go back to the C-suite or our executive champion and say, hey, we tried this and it's actually not working effectively. And we have to be very adaptable and remove obstacles as much as possible. Part of that is communication. I was actually listening to a presenter at a conference recently, and she was talking about the words that you use have meaning. And I thought that was such a true statement, and I thought, well, everybody knows that. If you say the wrong words, you're going to convey the wrong message. Well, it's more than that. If you say things like little or small or can I have a moment of your time, believe it or not, the psychologists have proven that it actually has a negative impact because of the connotation. So those little changes in their verbiage make such a huge difference in how we communicate to others and offer that level of mutual support. Now, they also have a program in the Team Steps curriculum that talks about using cuss words appropriately. And I'm not talking about the cuss words that we're all thinking about. I'm talking about professional ways to communicate a concern or some type of safety issue. So perhaps imagine this example of you're walking past an ICU bay and you notice that there's a physician, maybe the chief intensivist, is inserting a CBL. And they're not wearing a mask or a gown, but just regular sterile gloves, and that's it. Well, we know that that's a breach of practice, but how do we address it? How do we actually go in without really confronting him in front of the patient and say, I have a concern that needs to be addressed before we can continue? And part of that is using this particular script of saying I'm concerned, and I'm actually uncomfortable with this practice, and I do feel that this is a safety issue. Now, what I'm not telling you to do is to go back to your facility and say, I'm going to go try this out right now with the patient. I think you need to be very clever in how you address this. And make sure that all staff members, including your medical providers, understand that this program is being put in place, and more specifically, how is it going to be communicated to the offender, if you will. You don't want to walk into the room and say these things because the patient may obviously become very scared, and they may feel you're incompetent. So it's important to develop some type of signal. A lot of times what I've seen in hospitals is that they'll just raise their hand and they'll say, can I have a moment of clarification, please? And everybody knows that's part of the care team, that that's a signal to step out of the room, step out of the environment, and stop the procedure in order to kind of regroup and understand that that concern has been successfully resolved. Bridging evidence-based gaps is also important. We have to figure out not only what are the gaps in the armor, but what are we going to do about it? I think part of the issues that we have just in healthcare in general, especially in nursing, is that we don't have a ton of evidence-based literature that's actually created, designed, and published by nurses. We rely on a lot of these clinical guidelines, especially for infection prevention, that come from others, especially physicians. And that's not something that we should be doing. We need to really create specific evidence-based practice that relates to our jobs. And I think that's why it's so great that the pediatric SIG has its own set of guidelines that address some vascular access questions, so that you can really come to a level of consistency, but also accountability and sustainability towards zero. But identifying what those research gaps are is a way that we can continue to expand the practice, but also expand the profession. If you start to answer those questions and publish those, it really helps all patients benefit from access to those latest evidence-based practices. Now, we are kind of at a transition point, if you will, when it comes to evidence-based practice. We have a lot of guidelines and resources and recommendations that exist out there that tell us and guide us towards infection prevention practices. But remember, I said at the beginning that only about 40% of the time do we do those evidence-based recommendations. That still is a 60% gap. So how are we closing that? Well, I think we need to look at more succinct guidelines and recommendations, and that's so important. Because if we don't do that, we're really never going to get forward in the sense of implementation, because we can't give someone a 35-page document for one procedure and say, you need to be familiar with all of this and expect that to happen. The more simplistic that we can create things, especially with the guidelines, the better off we're going to be. And I think that's the way that we really need to move. One of the things that I do really like about CDC's approach recently is they're posting executive summaries of all their new guidelines. And so if you're not familiar with that website to look at their infection prevention recommendations, you can actually go to cdc.gov/HAI. That address again is cdc.gov/HAI for healthcare-associated infections. All of their different recommendations are listed on there. You can download the actual full guideline, but more importantly, and I think is a better resource, is the executive summary. And this is everything from your procedure-related infections like bloodstream infections to quality surgical site infections to healthcare-associated pneumonias and management of MDROs. Pneumonia continues to be at the very top of the list as far as infections that are being seen by CDC. And that, again, was a very big surprise to me, because if you think about the work that's been done at reducing ventilator-associated pneumonia, it's very significant. We did, on a positive note, they'd see a pretty significant decrease with bloodstream infections, so that's very good. Another thing to consider is the actual grading, if you will, of the evidence. Now, different associations and organizations do this differently. Some don't actually have grading at all, which is okay. It's not ideal, but the more that we can get to, these are what the recommendations say based on this literature review, and here's the level of evidence and also implementation that you should consider. Now, I think where the challenge comes in is that when you do this ranking system and then there is no evidence, but there's a lot of best practice. Well, evidence-based best practice It implies to most people that you need to have it published in some prestigious journal. It needs to be in a guideline or something like that. It doesn't necessarily have to be. That would certainly be ideal because it helps us with national best practice. But we do know that there's a lot of circumstances that prevent many of us from doing that. And so really sharing those recommendations is helpful. But also understand the grading system is very, very important. Adherence to infection prevention and control, though, continues to be a problem. So if we agree that most of the infections, I'm not going to say all, but most of the infections are preventable with current recommendations, how are we going about fixing that? We have a gap here. We've got a 60% opportunity for improvement. Same thing with hand hygiene. Only about 40% of the time the healthcare personnel actually adhere to that recommendation. So we have to figure out, well, what are we doing wrong? Well, is it C-suite? Is it accountability at the unit level? Is it not observing some of these different practices? And I don't think there's a one-size-fits-all answer. I think it's so unique that we need to spend more and more time actually out on the floor so that we can see what those practices are and understand the challenges of implementation. Sometimes we may develop a policy and actually it doesn't work in the facility because it was developed by nursing leadership, people that are not physically taking care of patients every single day. And I think that makes a big difference. The other thing, too, is to create the infrastructure. So how do we create the number of not just physical people resources, but also systems and architecture, making sure that you have a conducive office environment. So many people in hospitals have been shoved into cubes. It really is very problematic for a lot of people because they cannot be productive in that sense. And so we have to consider that as well. But then going towards your administration, we've got to figure out how do we convince the C-suite of the role of vascular access clinicians in infection prevention. Yet we know that your patient satisfaction scores will go up. We know that your quality improvement processes will continue to get better if you have this dedicated vascular access clinician. And that's really not the purpose of today's webinar, but we know that from an infection prevention standpoint, that typically rates of infections are lower in places that have dedicated teams for vascular access that actually perform most of the functions like dressing changes. This makes such a huge difference. Now, let's spend a little bit of time as we get towards the conclusion of today's program and talk about how do we then translate that into not just a unit-based best practice, but a national and international best practice. Well, the first thing we have to do is learn. We need to learn from our mistakes. We need to learn from our successes. And we need to be very willing, open, and transparent to sharing these. Now, that can be problematic with legal and public relations, and so we have to balance that act very delicately. But there is a way to do it, and I think that's so, so important in order to share that. But let's say that you take something and you develop a new process, not even a new product or anything like that, but you change your process of how you care for central line. It involves everything from the insertion point all the way through the maintenance and the discharge. And you start looking at that evidence and you say, wow, this is really evidence-based, but I'm not familiar with these articles. And then you go and you see that the articles are in some trade publication, not in a respected peer-reviewed journal. That should be a red flag. So we have to also balance common sense as well. One thing that also happens is somebody may say on the unit, well, hey, this person got a class and we did everything right. Well, you may have done everything right that you know of, but going back and doing a root cause analysis at that unit level is extremely important. It gives you kind of a viewpoint into the actual system. It tells you what potentially may have gone wrong. Engage the patient in that if you're able to, especially if they're still admitted to the facility. So we take those unit best practices that we've demonstrated and we should replicate those. They can be replicated across the facility in other units. Particularly, we like to do this in like units so that we can get a good point of comparison. But we have to share that with our institution. Say, here's what we're doing. Here's what we suggest you do. Can you try it out and see what level of success you get? And maybe you do get a higher level of success. That makes a big difference. So then you take that to the next level and you say, okay, well, how do we do this on a regional and a national level? Well, you may be part of a health system or some other type of aggregate group. You can share that with your peers. You can share it at your professional conferences. Don't ever be afraid to share best practices. It's something that has been very problematic for a lot of people because they don't want to share their secrets, if you will. But there is a way to do this professionally as well as maintaining the integrity of your facility, because when you're publishing infection rates, a lot of people in public relations and legal get very upset about that, and I certainly understand that. But we should never be afraid to show our success and also our progress towards success. That's just part of who we are. So here are a few examples of CLABSI-specific stuff, and you talk about not just prevention research, where maybe you're looking at chlorhexidine bathing, an impregnated catheter, whatever it may be, but then it could also be an outbreak investigation. I mean, I have a little personal mantra. I always say, never let a good outbreak go to waste, because you can learn so much from that. And the more that we learn, the more successful we can be. I recently actually purchased the new iPhone 6, not the Plus that looks like a small TV, but the regular iPhone. And I purchased it on Saturday, and I already had an issue with it. And I have to tell you, I was so impressed with the level of sophistication and the way that they treated me as a valued customer, but more importantly, the information they took away from it. They asked me a lot of questions. Well, what was happening when this issue took place? How long has it happened? Can you replicate the image? These are all things to garner evidence that we've been talking about. And it helps us to understand what it is that our end goal is, our hypothesis, but more importantly, what's happening along the way. What are the milestones? How do we need to take it from one unit to the whole facility, from the whole facility to maybe our integrated health network, and then from that health network and publish it at national best practice? And that's really where you get the output. But part of this is then translational research. How do we then implement this at the bedside? So we know that we have a clinical best practice or an observation. That's kind of a no-brainer. So then we need to work it up to, how do we evaluate the hypothesis on a local level without a lot of resources, without having to go through a whole bunch of red tape? Then replicate that. If we can replicate it over and over again, especially in different facilities with the same outcome that was originally seen, then that gives us a high level of sophistication and confidence in that particular outcome. You could do something as simple as publishing it in an abstract or a poster presentation. I know that sounds very intimidating for some people unless you've done it, but it really is not nearly as bad as you think it is. And then taking that to a peer-reviewed written manuscript is the gold standard. We love to see things in the actual peer-reviewed literature, but it's important to do it in a way that shows not only the problem, but also what the solution or the potential solution might be. Then you need to actually conduct additional studies. And I think this is where we have tremendous growth and opportunity potential here. Well, there's not a lot out there about pediatric-specific vascular access. We rely a lot on evidence that's coming from the adult population. That information could then be taken and sent to CDC, to AVA, to other organizations that do write guidelines to say, here's what the local evidence shows, and here's the peer-reviewed published studies that show this information. Get some of you involved as key opinion leaders, and then you get the guideline developed. The average amount of time, believe it or not, for one guideline to get through the CDC is 2.5 years at a cost of about $250,000 per guideline. I mean, it's just astronomical how much is spent to develop this evidence-based piece of literature. And I think that really speaks volumes to how seriously they take it. So they're not very fast to put out guidelines, but they certainly do take the process very seriously. So then once you get that guideline out there, how do you disseminate that? Maybe there's, let's say, a NAN guideline for neonatal nursing. Well, if you're not a member of NAN, the chances of you having that are very, very slim to none, because you would have to know about it, you'd have to purchase it, you'd have to purchase it at the non-member price, unless somebody just shared it with you. So these are examples of how implementation and dissemination can vary from facility to facility. And I think there's so many different recommendations out there that exist. Just 1,500 alone are Category 1 recommendations with CDC for infection prevention. And that is just frightening to think about how many recommendations exist out there that we should be implementing. There's just no bandwidth great enough in order to accommodate that. Then the last piece that I think is one that most people don't particularly care for, but it helps us be our barometer of success, is measurement. We need to look at our outcomes and evaluate the system. Evaluation can be both formal and informal. It can be on the unit. It can be online. It can be through an anonymous survey. You name it, you can do it that way. But we want to validate, are we achieving the outcomes that we set out to originally achieve? If we are, then we know that we're moving in the right direction. We should continue to move down that path and really foster that communication to the staff about how important it is to take this practice and implement it. And if they say, hey, well, this is going to add 3 minutes to my already stretched workflow, we need to rethink that and figure out what can we do to expedite the process but still get that evidence-based practice to the child every single time. That makes such a huge difference. Now, I kind of finish up, if you will, with an example of an evidence-based practice specific to the use of antisepsis on the skin, but also looking at the anatomy of the skin. So we know that the skin just historically is broken into the epidermis and the dermis. The epidermis is where the transient or bad bacteria that actually cause infections are typically found. The resident bacteria is very deep within the dermis and the hair follicle, and it's not easily removed through the antiseptic process. But we know that the skin is the best natural barrier for infection prevention when intact. But of course, with vascular access procedures, we're really making nicks or pokes or cuts, and so we're breaking apart that natural barrier. Now let's translate that into neonatal CLABSI. Well, there's a huge risk for neonatal CLABSI, especially with those patients that have CVCs. They can be very difficult to diagnose and treat sometimes. You may have, obviously, an infant with other comorbidities that can really contribute to mortality and morbidity. The length of stay in the hospital costs goes back to what that AAA was talking about that we started with. And then standardization of procedures is not unique in pediatrics, but you do have specialized patients that do differ from adults. And they're much more resilient, so you see a positive outcome happen faster typically than you do in adults, but there also is more to go wrong. If you've got this flailing child and you're trying to put in a PICC line or something like that, it's just very different than an adult that at least can most times be still, and so it creates some particular challenges. So if you take that further and you look at an example of an evidence-based practice, this is from the late Dr. Janet Pettit. She looked at clinician knowledge of something in the neonatal intensive care unit, a specific process. In this particular case, it was chlorhexidine use, and she wanted to understand what was the clinician's knowledge base. What did they think should be done compared to what really should be done? And then there was an educational intervention to show them what the evidence said, and then a post-follow-up. And it was amazing to see her data point towards how few times clinicians at the bedside truly understand what the evidence says. It may be that they're not exposed to it. It may be that they were exposed and they've simply forgotten, or there's a point of confusion. And all of those are things that we can remedy by doing good staff education, sharing with them very simple, not complex systems, and also documents and reference sources. We don't want to give them a 300-page document to go home and read. That's not going to be very practical for their use. This is an example, though, of how the alignment also takes place with evidence-based practice, and this is just one for skin antisepsis, but you can see that you've got the CDC, INS, SHEA, the Joint Commission, Infectious Disease Associates, our Society of America, and APIC all lining up to say these are the different recommendations that we have. Same is true for your port and hub cleansing. But the evidence doesn't always reach the bedside clinician, and that's where we need to continue to improve. And we have to spend more and more time with these clinicians in order to help them understand what they do in the clinical practice setting makes such a tremendous difference. And we have to bring that all the way down from the top to the bottom. The need for healthcare-associated infection prevention research is very important. We kind of have three basic stages as CDC defines them. You have the prevented infections, the preventable, and the prevention approach unknown. This is really where we have growth opportunity that may take place. Part of this is that we know that we have prevented certain infections. A lot of these are vaccine preventable. That being said, measles is a perfect example of where people are not properly getting their vaccines for whatever reason, and we're seeing measles outbreaks. We know that every year we have many healthcare providers and others that do not receive their annual flu shot for whatever reason, but that puts them at more significant risk for the development or contraction of some of these illnesses. Then you have the preventable infections where we know what to do, but we're not quite there as far as implementation. So we haven't fully developed all the tools and resources and support mechanisms in order to not eliminate, but reduce the incidence of these infections. And I think that those are the two biggest areas. But the one that excites me the most is the prevention approach unknown, where we don't know the answer to the research question. Maybe it's, well, what should you do for a neonate at this gestational age as it relates to antisepsis? Or what about how often should you bathe the child? Well, some of these questions may be things that we don't know the complete clinically indicated answer. We may have a hypothesis. We may have a personal opinion on it. We may have expert opinion out there. But creating actual evidence that shows something is better than another is really the core definition of comparative effectiveness. And that's where we should move towards, is getting that ongoing research out there. And that's where you can start to publish this information, especially if you're an academic facility. Get this information out there. Share it with your peers. Really get it at the forefront of the actual practice setting. So if we look at the formula for success, it's really combining the disciplines, such as vascular access, with the evidence-based practice to get to your end goal of infection prevention. And again, it's not something that you're going to be able to do overnight. It's not something that can only be done within the scope of just the field of nursing. It involves your physicians. It involves your environmental services professionals, your infection preventionists, your dietary workers, your nurses assistants, your receptionists. Everybody owns a unique part of it. And it can be everything from hand hygiene to ensuring that someone is monitoring the insertion of these invasive devices. And I think that's really where we need to move towards, is more involvement. And I started and I want to end with the patient. The patient has to be the cornerstone of everything that we do. And I have so much respect for when I go into some of these facilities, especially pediatric facilities, and you can see it, you can feel it, it's palpable that the staff is truly trying to do what is right for the patient, even if it's a very unpopular condition. And I think that's something that we have to do more of. The other thing that I'd like to leave us with is we have to create more evidence. So take something that worked in your facility or even something that did not work. Publish that work. Publish it in the form of a poster. Share it with your colleagues. Invite others to a professional society meeting like AVA, and get that information out there as much as possible. We all too often live in a world of we don't have enough time, or it's going to be too much trouble to publish that. There are lots of resources out there. If you want to publish in the journal, if you will, for AVA, there is a way to get some editorial help with that. So these are all things that we can continue to do. And then last but not least is, for us to achieve safe healthcare, it has to be part of everyone's radar screen. It has to be on everyone's radar screen, from the C-suite to the government, to the insurance agencies, to the patients. Public health is a piece of this. If you look at Ebola right now and enterovirus, a big part of that response is CDC and local and state health departments. You have to be coordinated with them. It can't be that you wait for an outbreak to take place in order for you to really build that relationship. So we'll finish with this slide, and then I'll open it up to any questions and answers that you'd like to go through. But hypothetically, if you knew that you could do something simple, easy, cost-effective, and that we knew was evidence-based, but it took a little extra time, would you do it? And would you do it knowing that your extra time, energy, and commitment would make a difference to a patient, whether it be from eliminating the risk of eclampsia or reducing it to preventing a patient death at its most severe consequence? Would you do it? And I think that's the question we have to ask our peers, not just ourselves, but our peers, and have those very candid conversations with the people that we care about, that we work with, and really move towards that. So with that, I will open it up for any questions. If you do have a question, you can actually place it right in the chat box, and I will be happy to answer as many of those as we have time for today. One question that looks like it's totally unrelated to this is, what's the status update on Ebola, since I mentioned that, and I guess I did open the door for that. There is a lot of work going on right now with Ebola to prevent it from coming to the United States, and I know that especially with the enterovirus issues that are taking place in pediatrics, it is something to be concerned with, as well as Ebola. But the current status of that is, as of yesterday, was the latest report that I received from CDC, we're well over 5,000 cases over in the West African countries, and about half of those people have died. So the average mortality rate is anywhere from 50 to 60%. It is not something that we are grossly concerned with coming over to the U.S. as far as a mass issue, but it is something that the CDC is working very rapidly towards. They've got a lot of resources deployed overseas, but it is not something that they're significantly concerned with coming to the U.S. because of the way that we're set up, our healthcare delivery system, that type of thing. The next question is what is the update on enterovirus, and as it relates to pediatric facilities? And I think that's certainly a very pertinent question. This particular enterovirus, the challenge that we're facing is that it's not a unique virus in the sense of we haven't seen it before. We actually see it, and have seen it for many years in pediatric facilities as well as other places. It has not caused the level of mortality and morbidity, however, that we've seen with this one. So it's not that it's mutated. It's one of the family of the non-polio enteroviruses. And I believe, if I remember correctly, that the virus was first found actually out in California back in the 60s. It's something that we do see seasonally, so we're kind of at that point where we would see it, especially at the very beginning of flu season. But we're continuing to monitor that. If you look at the number of states that have had it, it's really huge. I believe we're up to 32 states so far and about 220 cases, which doesn't sound like a lot, but if you think about that from a patient's perspective, especially those respiratory compromised patients, those kids with asthma and things like that, they can be very problematic. The next question that came in is there a specific resource that you might direct me towards to actually learn more about evidence-based practice so I can stand up to a difficult physician? And I think that's an excellent question, and one that I would direct you to a couple different resources. If you're a nurse, one of the places I would send you to would be the Johns Hopkins Evidence-Based Review course. You can actually take it online, or you can take it in person, and it really goes through what does the literature say versus what's the practicality of the implementation. And it helps you dissect certain pieces of literature, whether it be nursing or medical, and really move towards the goal of breaking down silos, improving communication, and also understanding what you're presenting. And I think that's part of it, is that a lot of times we communicate to physicians, as an example, with nursing literature. Well, they don't necessarily want to see that. They want to see what the medical literature says. And so we have to find that fine balance of saying, here's what the literature says in general, here's what the practice is, and here's where I think we can compromise and come to a resolution. And I think that's something that we have to continue to do a better job of. That being said, as a little bit of a tangent here, we have to create more nursing research. We cannot rely on physicians to write guidelines. I'm not saying there's anything wrong with physician involvement by any means, but physicians don't take care of patients in the same way that a nurse does. And so those guidelines should really originate from bedside clinicians and clinical leaders in the nursing field and specialty. You're never going to see nurses necessarily write medical practice guidelines unless they were done, obviously, in collaboration with physicians. And so we have to continue to work across disciplines in order to pave that way. The next question that came in is there anything specific that we should do to improve hand hygiene with patients? We know that the evidence suggests that if we can decrease, that we can decrease healthcare-associated infections with improved compliance for healthcare workers, but what do the recommendations say about patients? That's a great question. There's not really a lot of recommendation out there about patients, other than we know we should involve them in their care. But if you go to the new Society of Healthcare Epidemiology of America, which is shay-online.org, you can actually download their new compendium for hand hygiene. And for the first time, they actually talk about patients need hand hygiene as well. And they specifically address bedbound patients, those patients that can't ambulate, and the importance of bringing them hand hygiene. And I think it goes back to, again, involving ourselves and the patient together. We've got to make sure that they feel like they're part of the team and that they have a say-so when appropriate, or their parents. And so I think that's something that you can look at. And it looks like the last question that we have is there anything specifically that we can do to create evidence where we know that common sense has already prevailed? And I think an example of this would be hand hygiene. We don't need any more evidence for hand hygiene. We all know that it works. We know that it makes a difference. But a lot of people have pushed back. I remember one time a dermatologist, believe it or not, pushed back on me at a presentation, and he said, "Hey, Hudson, I don't agree with you that you actually need to sanitize your hands because there's no evidence that says that." Well, there is evidence, but it is very limited compared to other things that we've studied. And quite frankly, we don't need to dedicate a lot of time and resources to common sense practices. We know that if we wear gloves, that it's going to decrease our risk for transmission to our hands, but we also know that a consequence of that could be increased contamination to the environment. So we have to learn from what we think are good things and also figure out what the negative potential consequences might be. And so that's just one thing to think about, is how do we continue to improve that. And it looks like that's all the questions that we have for today. I will be sending out a copy of the slides so that you can have those, and any of the links you should be able to click those as well. If you do have any additional questions, I will certainly put up my email address, which is listed there, as well as my phone number. I'm happy to take any questions that you might have after the fact. This does conclude today's webinar. You will receive a survey where you can complete the CEU evaluation, and we certainly appreciate your continued support of the AVA Pediatric Special Interest Group webinar series and also Stephanie's leadership on setting these up. So I hope everybody has a fantastic end of the week, and we look forward to speaking with you all soon. Take care.